Hey everybody, happy Thursday. I have a lot I want to talk about and I want to be quick and brief to get you guys on your way. So we are just going to dive right in. We've been talking about EKG stuff, basics, foundational things. So I want to talk about the famous Einthoven's triangle that I was like, I don't understand any of this when I was in school. So I'm going to attempt to break this down very quickly for you all. Well, before I do that, let me go back up here. So EKG really quick, anesthesia, right? Most patients, depending on their medical history, so depending on their age, maybe if they're over 65 or 70, if they have any cardiac history, arrhythmias, if they're diabetic, if they have renal disease, if they've had a stroke, something like that, we want to get an EKG within 30 days of surgery, all right? An EKG is a risk assessment tool, and also, like I always say, what's the patient's baseline? I want to know who this patient is when they walk into the operating room so I can pay attention and know and be vigilant if there's any changes, okay? So that's super, super crucial. So that is why EKGs are important. Now, EKGs, actually, let me go back again. I keep getting excited. EKGs are simply a graph, right? So all an EKG is doing is recording the electrical activity of the heart. And what is the electrical activity? It's the movement of ions, right? It's the movement of depolarization and repolarization. I guess he's excited too. So, we have our P and our QRS. P is atrial depolarization. The QRS is ventricular depolarization. And then we have the R wave, or the T wave, excuse me, PQRST. Then the T wave is actually repolarization. So what's actually happening in those times is when the heart is depolarized, when an action potential hits the heart, sodium channels open, potassium channels close, then sodium's close, calcium channels open to keep the depolarization going, and then to repolarize, the calcium and the sodium channels are closed and the potassium channels reopen, okay? So, and that causes the heart to contract. So it's that constant flow of ions that causes the contraction, that causes the electrical activity, that gives us the beautiful ups and downs and all the good stuff on our EKG graph, okay? So that's like the big picture overview, which I know most of you guys know. Now, super, super basic, not gonna spend a lot of time here. I just want you guys to have this information. But then, we have our limb leads, which are there. 1, 2, and 3 are the bipolar leads, which means that there's two electrodes placed at different sites and they measure the different action potentials. Bipolar means 2, right? Then we have our chest lead, which we know goes from V1 through V6. V1 and 2 is at the left heart. V3 and 4 is at the ventricular septum, and then 5 and 6 is the left chest. I think I said that backwards. 1 and 2 is right. 3 and 4 is ventricular septum, and then we have 5 and 6 is over like the left part of the chest, right? And those are unipolar, okay, along with the foot lead, AVL, and AVR. And that's just a single positive recording is what that means, okay? So I'm not gonna spend too much time here. I just want you guys to have this information so you know which leads are which, okay? All right, now let's break this down really quick because I want to make this not so scary and overwhelming and annoying when you're like sitting in your physiology class and you're just like glazed over, like what the heck is going on? So easy way to think about this. So first, we have Einthoven's triangle, right? And all Einthoven's triangle is this little imaginary triangle that this guy Einthoven's made up to help us understand the electrical axis of the heart, okay? So all we're looking at, we care about the degrees. What are the degrees? Because the degrees and the axis of the heart is going to tell us if there's any abnormalities when we're looking at an EKG, all right? So first of all, you have leads 1, 2, and 3, right? And then you have your AVF, your AVL, and your AVR, and all that is a flat plane. So that is literally just sitting here flat on your chest, right? And you can see the right arm goes to the left. It goes from a negative to a positive. The right arm also goes down to the left leg, negative down to a positive. And then we have the left arm goes down to the left leg, negative to a positive, right? So it's all about the direction, the degrees of where everything is going. That's it. And those leads are flat. So Einthoven's triangle, it's a flat frontal plane, okay? Now we have to add in the chest leads, okay? Now the chest leads are perpendicular, they point outward. So they're not flat, they're like this. So those are coming out like this, right? do a little dance for you guys. So you have this flat plane of leads moving in a directions, going from, you know, negative to positive, which is going to tell of our QRS deflection. And then you have the precordial chest leads that are sticking out, okay? So those are like coming out. Is that making sense? And the normal direction, so normals, right? We always want to know our normals. The normal direction of depolarization is going to go from the right to the left here, okay? The heart is polarized from the upper right to the lower left. That is the normal axis, the normal direction of depolarization, okay? And if you look at kind of some of the degrees you want to kind of pay attention to is if you see lead 1 over there on the axis is at 0 degree, lead 2 is at 60, AVF is 90, and lead 3 is at 120, okay? So remember, those are coming out and those are going in directions. So we're looking at where is the direction of depolarization going. That's what all this stuff is actually telling us, okay? And if you look here, so from 0, if you look at lead 1, if we go counterclockwise, we go in a negative direction, okay? And if we go clockwise, we go in a positive direction, like 30, 60, 90, like that. Okay, so that's it. That's all that's saying. Where is depolarization going? If it's, and we'll talk about this in a second, is it going a little bit more to the right? Is it right axis deviation? Is it going a little bit more to the left? Is it deviating? Because that's going to give us clues as to what is going on with the patient. Okay, I didn't go into the arrhythmias. We did talk about that on social media. We talked about SVT and all that stuff like that. I think you guys are pretty good with that stuff. I know this is the kind of stuff that can be kind of weird. Okay, making sense? And then just to close us out really quick, know your normals. So basically lead 1 and lead 2 are gonna be the main ones that are gonna tell you if there's some type of axis deviation. So it is normal for lead 1 to be a positive QRS, okay? Because we look back, look at where lead 1 is going. We're going from the right arm to the left arm. That is lead 1, okay? So it's going to be a positive QRS deflection. Lead 2 as well, if you look at lead 2, is going from the right arm down to the left leg, positive. That's going to be a positive QRS, positive deflection, okay? And then lead 3 can actually be positive or negative, okay? Lead 3 can be positive or negative, doesn't really matter. We're gonna depend on lead 1 and 2 to kind of tell us if there's any type of axis deviation, okay? And then I didn't go into charts. I'm going to put some charts up for you guys. So look for those or message me if you can't find them. I will get some charts up on the deflection things because that's going to tell you. Now, if lead 1 is positive and lead 2 becomes negative, okay, we're looking at a left axis deviation. So did the patient have an inferior MI? Do they just have some left ventricular hypertrophy from hypertension? Do they have a left bundle branch block? Okay, that's what left axis deviation is going to tell us. Now, if lead 1 becomes positive and lead 3 is positive and lead 2 is negative or positive, we're in a right axis deviation, okay? Right axis deviation, hyperkalemia, COPD, PE, maybe a lateral MI, something like that, okay? So that is all this is saying. We just need to know the direction of depolarization. And if you actually look on obese people, the heart is actually pushed like up and to the left. So their vector is going to be different. Their axis of depolarization is going to be changed, okay? Because the heart is kind of pushed up, okay? If they have hypertrophy, which you talked about, hypertrophy, the axis is going to move towards the hypertrophy side. So a left axis deviation is going to mean left hypertrophy because that's where the vector is going to be pointing to. If somebody has an MI, that area of where the MI is, anterior, lateral, inferior, wherever it is, that's going to be an infarcted site, right? So the vector is actually going to move away from that. So that's how that can kind of tell us what's kind of happening, where the MI is at, all right? So your EKG is full of tons of information. It can tell you so many things. You might need to get them post-op. Make sure you peek at one pre-op if your patient is a candidate for that, and pay attention to the abnormals, the changes, because that's the job, okay? All right, I hope that was helpful. If you guys need anything, you know I am here for you. Have an awesome, awesome rest of your day, and I hope you have a good weekend. Bye.